government's watch, people across this country are spending money out of pocket for surgeries, $30,000 for a hip surgery. When will this government finally stop American-style healthcare from entering our country?
The choice I had was to register with OHIP and hope that maybe you'd have the operation in 6 months, or go to a private clinic, which I did, and I had both my eyes fixed in 6 weeks.
Hey there, I'm Andrew Chang. Welcome to About That. Healthcare, it's not in great shape in this country. And you know, there's been a lot of discussion in the media lately about private versus public healthcare. And you know, it's no surprise. People are waiting months and months, sometimes even longer than that, for simple surgeries, and they're sort of feeling desperate for options. And some think that opening the door to private care is going to fix our broken healthcare system. Others say, hold on, private healthcare is fundamentally wrong, and we shouldn't allow people to pay for care, essentially, you know, butting in line, jumping the queue just because they've got money. But what sort of gets lost in this whole conversation is what private healthcare actually generally looks like in this country, and where provinces are actually taking this conversation. So let's start with this. According to a Statistics Canada survey in 2021, almost half of adults across 10 provinces had difficulty accessing healthcare in 2020 and 2021. Close to 15% say they didn't receive the care they needed at all. And in some parts, private clinics have moved in to try to fill that gap. So, you know, in BC, some elective surgeries like hip and knee replacements, diagnostic imaging. So, you know, on that front, we're talking like CT scans, MRIs, and other procedures. You know, they routinely get contracted out to private clinics. Both Manitoba and Saskatchewan are attempting to deal with backlogs by paying private clinics outside the province to do surgeries. And last month, Ontario unveiled a plan, not entirely unlike BC's, where more surgeries and diagnostic procedures would move out of hospitals and into private clinics.
Ontario's premier says working with private clinics will help the public healthcare system.
To start, we're tackling the backlog of cataract surgeries, where we have some of the longest waits.
And Doug Ford insists that won't mean paying out of pocket.
All of these services, they'll be available using your OHIP card, never your credit card.
So cataract surgeries to start, but branching out into other elective surgeries as time goes on. And the basic idea here is to lower wait times, right? By kind of opening up this separate healthcare pipeline, but still within the public system, just using private resources, but paid for by taxpayer dollars. Now, this is not the easiest thing to understand, but we have just the right person who can help explain all of it to us and give us a good sense of why, you know, even the most optimistic people are saying we should tread carefully on this. CBC Health reporter Christine Birak, how you doing?
Good to be here.
Yeah, no, hey, thanks for being here. So we've got a lot to talk about. And I guess, like, let's start just by setting the terms, because when we talk about private for-profit healthcare in this country, we're not always talking about the extreme end, two-tier healthcare, jumping the queue, I get the best healthcare just because I've got the most money. It's actually quite a bit more subtle than that, right?
Absolutely. So, yeah, let's try and break this down. I do think that in order to better understand it, you do have to follow the money to some degree and figure out who's paying for what. So I think just as a starting point, you have to understand that pretty much most doctors are all private independent contractors who get paid for a service.
Right, they get reimbursed by OHIP, for example.
And it kind of depends on who's paying them for that service that makes a difference. So I'll give you an example. Let's say you need knee replacement surgery and you end up in a hospital to get that knee replacement surgery. The province pays the hospital a fee to do your knee replacement surgery. And an average price in Canada is about $10,000. So that includes the surgeon, whatever you need for the knee replacement, the staff that's there, the hospital. the hospital gets $10,000.
And I, as a patient, wouldn't be out of pocket for that.
No, you do not pay for anything in that instance. But let's say you want that knee surgery, you want it right now, you feel like I can pay for this, I don't want to wait at all. You could go to another province and you could get that knee surgery right away. Our research shows that it will cost you, the patient, up to $28,000 to do it that way.
So significantly more money that I'm out of pocket, but I entirely skip the line. I can just get the surgery when I want to get it.
Exactly.
Right.
So now we come to what you're describing, and that is the provinces are willing, and we always say province, but this is taxpayer dollars. Let's just remember,
Yes.
we are all agreeing that the hospitals are full or overwhelmed, and so let's take out some of these patients and we're going to pay for their procedure in a private clinic. So we asked, okay, well, so what happens when you want to get your knee replacement now in a private clinic? So how much does that cost?
Right, but it still costs nothing to me because this is still within the public system, right?
Well, it shouldn't, in theory, cost you anything.
Yeah.
And we'll get into that because BC has seen different outcomes as a result of
Right.
this. But yes, so in theory, that whole idea that you're going to pay with your health card, not your credit card, you go into the clinic, you get your knee replacement surgery. And we wanted to find out, well, how much does that cost taxpayers, or how much is the province then paying?
Sure.
And that information is actually kept secret. We cannot find out how much the province pays a private for-profit clinic to do your knee replacement surgery.
That's kind of an important piece of the puzzle to know, though.
It is, but the clinics themselves say, hey, this is part of confidentiality. The province also blocks us from accessing that information, saying that it's part of contracts that we have. And our question in this, for sure, and to your point, is that, well, where's the accountability for taxpayers?
Right.
How much exactly are we paying into these for-profit clinics? And, I think it's important to note that the difference, and this is a question that some people might be asking, why does it cost $10,000 if you get it in the hospital, but $28,000 if you get it in the clinic? And really the difference is profit. How much are people making on the back end of this?
Okay, so I can accept that this is sort of a big piece of the puzzle that we just don't have right now, right? What the cost of the province would be in this sort of public-private hybrid model. But do we know enough about how it would work to know whether it would work, right? Like what's the argument here? So if you outsource some of these services and surgeries to the private sector, paid for by the public system, like what's supposed to happen when you do that?
Right. So the expectation is that, we sort of attach a lot of things to the word private. We kind of think that it's going to be, and I think sometimes this is promoted, that it's going to be more efficient financially. Is it going to be cheaper? What if we get people out of line and get them into these clinics? We'll make the lineup shorter. So is it faster? Which evidence has shown we haven't really seen it work out that way. But overall, and this is what I thought, okay, let's say even if provinces are paying more, we want people to get their surgeries. So are the wait lists shorter? And ultimately, that's what we want, is people to get their surgeries faster. And so Ontario has said, hey, listen, we are following the lead of BC, Alberta, Quebec, and they are doing a lot of these surgeries as it is in these spaces, right? So we're talking about, as you mentioned, cataracts, hip replacements, knee replacements, things like that. Those are the surgeries that are largely backed up. So we thought, okay, if BC has been actually doing this for the better part of 2 decades, let's take a look at wait lists. So there's the Canadian Institute for Health Information has data on how long Canadians are waiting in various provinces for various procedures. So we took knee replacement surgery as an example. And as it turns out, when we looked at the data, Ontario actually has shorter wait times for hip and knee replacement surgeries than Quebec, BC, and Alberta.
Than some of those provinces who have been outsourcing to the private sector for, as you say, years, if not decades.
So that struck us as, and we're not talking huge differences here. We're talking that, I believe in Ontario, upwards of 70% of people get their knee replacement surgery within 6 months. And in BC, it's about 68%.
Okay, but explain the logic there, like how that works, because like if I understand the theory correctly, it's by opening up this other stream where you can divert patients away from hospitals and such in the public system into private clinics. You're freeing up the bottleneck, right? You just have more people who have more choices. The throughput is greater. Wait times go down. So how is it that? So
here's what I think, and I completely see where you're coming from right now, because I looked at it the same way. But there is a logic problem in here somewhere, because we talked about the fact that we don't know how much it's costing. Now I'm telling you that wait times actually are shorter in Ontario as it is without these clinics.
Right.
And I started to think, well, why exactly is that happening? And the interesting thing here is that we kind of think that these and knee and hip replacement surgeries, they're not minor surgeries, but they're less complex surgeries than a lot of what happens in the hospital.
Sure.
And you kind of think to yourself, well, let's get those people out of line, just like you said, and then we'll make room. The issue here is staffing. You know, well, actually, I'll back it up one thing, because another part of the issue here is that we kind of think that if you open more clinics, we have more operating rooms.
Yeah, just have more capacity.
Exactly.
Right? Yeah.
There will be more capacity. And there's logic in there to think if there's more capacity, then we can do more surgeries, we'll get people through the system faster.
That's right.
So I went to go see the head of surgery at Women's College. We sat down late in the day in an operating room. And I said, the same thing. I said, but if there are more operating rooms, we can do more surgeries and that'll move people through faster. And he looked at me and he said, Christine, we are sitting in an operating room right now that's not being used.
Right.
You could use this operating room. And he's like, we could run these operating rooms 24/7, evenings, weekends, you know, surgeons could come and work in these rooms. He says, the problem isn't spaces, it's people.
The limiting factor right now is not places. We don't need new places. We need people. The bottleneck right now is particularly nursing care. In some areas, it's respiratory therapists, it's anesthetists to a certain extent. We've got lots of facilities, and we can use all of these existing hospitals if we had the people. So we have to have trained nurses who are able to work in these hospitals, and we also have to have funding to be able to pay them and to support all the other needs that happen in hospitals.
Okay, so you don't have the nurses. So what happens when you open private for-profit clinics? And he said, well, therein lies the big problem.
You're pulling people
Exactly.
away from this public system.
It's the same pool of nurses and doctors. Right. And we don't create healthcare workers. I mean, there are people who are graduating, but you can't suddenly have, you know, a whole whack more of doctors and nurses. So there's a pool, and now suddenly, let's say somebody's offering you twice as much money to go work in a for-profit clinic.
Right.
Right? So I don't think you can stop a nurse or a doctor or a surgeon from saying, oh, wow, like somebody's willing to pay me twice as much over here. So they get out of the public system or, you know, and go work on that side. Well, now the pool is shrinking for the hospital of staff. And we've already taken out a lot of the less complex procedures.
Right.
What's left over here are more complex procedures.
Fewer people to do more difficult work.
Fewer staff.
Hold that thought. I have many more questions for you, because I also do want to talk about solutions at a certain point
absolutely.
here. Christine Birak will be back with us after this.
You could do operations in this operating room. You don't need to open up new facilities.
And he says hospitals are only funded to do a specific number of surgeries per year. Governments could pay to schedule more on evenings or weekends, but the real issue is staffing.
We need people. The bottleneck right now is particularly nursing care.
But for-profit clinics recruit nurses from the same pool of workers. A nurse or doctor leaving for more money leads to longer wait times in hospitals.
I really worry that people don't completely understand the long-term impacts of some of these changes.
Hey, welcome back to About That. We are indeed talking about public health care in this country, and where public health care meets private health care, and whether a hybrid model, which is something that many provinces are sort of increasingly turning to as a potential solution to our healthcare crisis in this country, whether that hybrid model actually introduces the sorts of efficiencies we would expect. And Christine Birak, a CBC Health reporter, has been walking us through this. And we're talking about wait times just before we took a commercial break there, and how we found that wait times, even in provinces where this private model has injected itself into the public, how they kind of just stay the same, which is sort of surprising.
They do. And in fact, there's evidence that in the hospitals, actually, the wait times get longer because they've lost staff. And so now people need to wait longer for more complex surgeries in the public system. So there is this sense that, I mean, where are the gains here? What are we supposed to be gaining?
When we do look at, I mean, so that's the public side of it, or the public facing side. When I look at the private clinics, tell me more about that, because I don't know, when I imagine and this is just stupid me thinking, right, with my layman understanding of things, but like when I think of a private clinic, I think, well, this is going to be a fancier facility. It's going to be sort of like flush with cash, and so that kind of goes back into the care. And as a patient, I will have a better experience and maybe even better outcomes as a result. Like, is that the case?
I think it's really good points, because I think that there is a perception that that's how it works. But I think we're sort of losing the understanding of what for-profit. I mean, people say private, but it's really for-profit. And at the end of the day, these clinics exist to make profit. Yes, they are doing care, but at the end of the day, they wouldn't exist if they weren't making profit. So I think actually a really good example of looking at this in Canada is long-term care. So the long-term care in Ontario specifically used to be all public, and it was they started to hive it off and allow for private care. So in those facilities, people still feel that, in private care, exactly what you described. But we saw during the pandemic that what for-profit care meant was there were more patients in a room, there was less staffing, there were higher death rates in private for-profit long-term care homes than there were in public homes.
Studies of the UK and US have also shown private for-profit care can lead to slightly higher death rates.
So when we're looking at private financing in our system in multiple examples, it tends to have worse patient outcomes and tends to have more financial inefficiencies. So why would we be looking to expand that aspect of our existing health system?
And we've also seen studies that look at death rates in for-profit care. And I don't want to be alarmist in any way. It's that they're higher. Preventable deaths have been found in studies to be higher in the UK, where they've introduced it, and in the United States, where the model is full-blown. So, I mean, there is this sense that if there can be efficiencies, I haven't been able to see exactly. I didn't find, we don't know how much they are costing taxpayer dollars in terms of being cheaper, in terms of being faster. We don't see wait lists go down. And in terms of being safer, there would have to be a whole new regulatory body in Ontario, which Ontario has not said how we're going to actually police these new clinics and make sure that they have the same standards as hospitals.
Right, because hospitals have very high standards, right?
Oh, absolutely.
Yeah, where they're constantly being checked. So if this introduction of the private system into the public system doesn't necessarily grant us efficiencies on those three fronts that you just mentioned, not necessarily cheaper, not necessarily safer, not necessarily faster, like that sort of leaves me wondering, okay, so now what, Christine Birak, right?
Where are the solutions?
Where do we find the efficiencies that we're looking for and that we need in this country?
And so I think that that's a bit of the frustration that some of the doctors that I spoke with are having. They feel that they're not sexy solutions like, use your OHIP card or health card to pay for stuff. They're actually operational things that happen within hospitals and the connectedness of some of these resources. But one of the big ones in terms of surgeries, so when we look at surgeries in particular, I asked doctors, surgeons, how can we make this system better? If it's not moving some of these surgeries out, how do we? The first thing they said is actually the provinces could fund more surgeries within the hospitals. So this isn't something that I realized, but hospitals are only funded to do a certain number of surgeries per year, even though we can largely predict based on history and age of population how many surgeries are going to be needed. There isn't really the work going in to make these predictions more of a match.
And as you said, there is capacity there. If there was funding to do more.
Yeah.
Right.
The staffing is still an issue.
Sure.
But another thing that they brought up was centralized wait lists. So we are often talking about these huge wait lists. Yeah. And I had a surgeon say to me, there's no wait list, Christine. Every surgeon has their own wait list. So let's say you go to the doctor, you need a specific surgery, your doctor refers you to a surgeon who has a very long wait list. Yeah. Now, all of a sudden, you're on a very long wait list.
I'm just stuck on that list.
You are. But let's say I go to my doctor and he sends me to another surgeon who actually has a very short wait list. So I end up getting my knee replacement surgery before you do.
But wait. So there's no mechanism where those two surgeons would talk to each other and say...
And your doctor can't even see their wait list, has no idea who has the longest wait list or who has the shortest wait list.
Well, that seems silly.
It does. So the Ontario Medical Association, and we've seen this happen. We see it happen in smaller groups where there should be a centralized wait list, kind of like a call center. It's like all of these calls are coming in and you get the next available operator or you get the next available surgeon. And it's like, well, okay, so your request is your referral has gone in. Andrew, there is a surgeon at, maybe it's even a little bit farther away, but maybe you're willing to travel that far and you want that surgery right away. Now, it would make sense that you then, it's a system that's just far more efficient. It just sends you to the next available surgeon rather than sitting on a wait list. We asked, well, what's the opposition to this? And we were told by a surgeon, often it's surgeons, because they like to hold on to their wait list because their wait list is a guarantee of income. And in a fee-for-service model, which means you get paid for every patient that you see, you want to know that you have the security of my income is here. What doesn't make sense in there is that there is so much work right now that they don't need to be holding on to these wait lists. And you'll also hear from patients who'll say, well, then how do I get to choose my surgeon? And I think that's what's interesting in a lot of these discussions is that there is a small percentage of people, I'd say up to 10%, that are sort of, uncomfortable about some of these changes, but it's affecting everybody else at the same time. And so, I mean, for people who do want their own specific surgeon, we could probably work that out. But this system needs to change. And in terms of the operational, like the communication between hospitals, all of these things need to be upgraded. And I spoke with an expert who said, this is a health policy expert, so not a doctor. And he said, if you look around the world, our system is not working well right now. If you can get 60% of people happy, there is no perfect system. The highest approval ratings we've ever seen for healthcare are around 60%. So we shouldn't be tearing down what actually works really well. We should be building on top of what is actually the most cost efficient, the safest, and the most time effective in getting people the surgeries they need.
Christine Birak, we have come so far and yet only just scratched the surface. Such a wonderful conversation. Thank you so much.
Very welcome.
And we'll be right back after the break with a little sneak peek at something we're working on for tomorrow's show. Hey, welcome back to About That. Just before we close out the show for today, thought we'd give you a little sneak peek at something we're working on for tomorrow. Because on Wednesday, we're expecting the CEOs from 3 major grocery store chains in Canada to appear before a parliamentary committee in Ottawa that is looking into the high prices that we pay at the grocery store. And grocery stores, we're talking about Loblaw, we're talking about Metro, and Empire, which owns Sobeys and IGA and a few other companies. So we thought we'd ask, how did we get to this point? So here's what I did. I looked up StatsCan data from the last year, and this is a list of more than 100 different products that we might buy at the grocery store. So, everything from milk to frozen pizza to yogurt, potatoes, tomatoes, canned goods, vegetables, fruits, meat, you name it. And what I did was I looked at the prices that have increased the most over that time, just so we can get a sense of how things have changed. And then we went and bought a whole bunch of those things to see what the prices are today in Toronto. And so tomorrow, what we're going to do is we're going to look at which of these items have actually increased the most. We're going to try to explain why that is. And then we'll look at how accountable the grocery store CEOs may be held on Wednesday. We'll see you then.